Hello, everyone. Welcome to the Independent Sage Friday briefing. It's 2 years since it all started and COVID is still around. And as we've seen in the past few weeks, infections are continuing to rise. Hospital admissions are also going up at an alarming rate. And in fact, COVID-19 hospital admissions are the highest they've ever been since the second wave. So this adds to the existing pressures on the NHS. And we're also seeing the devastating impacts of long COVID, with people suffering from fatigue, shortness of breath, loss of taste and smell, and many other symptoms for months after they've tested negative. And according to the ONS survey published yesterday, a record 2.7% of the population in Britain are suffering the brunt of long COVID. That's the highest it's been since the collection of figures began a year ago, and presents a huge challenge again to the NHS. And all this clearly just says one thing: the virus is still around and a cause for great concern. And given the fact that the government has done away with protective measures, as well as a lot of crucial data collection, an environment of uncertainty prevails. So this week, we're going to bring to you a dedicated public question and answer session where you can put forth your concerns. And we've got a whole number of interesting questions. But before we move ahead with that, I'm going to invite Professor Christina Pagel to present us with the latest on the virus. Christina.
Hi, let me share. So I'm going to try and cover quite a lot today because we're not having a session next week because of Easter. We don't have any special guests this week. So kind of a quick roundup of vaccination, prevalence, hospitals, deaths, children, long COVID, and new variants, since we've not talked about that for a little while. So just on vaccination, a quick update. We're not doing anything really apart from the spring booster program. And vaccination of 5 to 11-year-olds has literally just started, but there's no data on that yet. But we are making good progress in the spring booster program, and over a fifth of those eligible have now had their spring booster. So that is good news. Looking at prevalence, I'm going to start with the REACT-1 report, which is a monthly analysis coming out of Imperial College, where they test about 100,000 people every month for COVID. It's been an absolutely incredible study. Its funding has been cut. This is the last report. So I want to just show the last slides from that. And it is literally going out on a high at the highest ever prevalence that they've seen at 6% and a bit of the population being affected in those 2 weeks in March, which does chime very closely with the ONS infection survey. And you can see this was the first Omicron wave in December, and this is the second one that we've just had, or just in the middle of, in fact. Just comparing March to February, you can see that the southwest, basically the south and the east of England, have been the hardest hit in the BA2 Omicron wave, although all parts of England saw massively increased prevalence between February and March. And in children, by ages, you can see that again, this latest wave has been most severe in primary school age children, but every single age group in England has been affected. Going to the ONS survey and the latest results that came out today, effectively, Scotland, England, and Wales almost now have exactly the same prevalence. About just over about 7.5% of people have tested positive in the most recent week, which is incredibly high. Scotland has peaked. I think England probably has, Wales probably about to. But what's a little bit concerning is that Northern Ireland, which looked like it peaked well over a month ago, has still got really, really high rates. And that's kind of wondering, are we going to come back down, or are we going to be kind of staying up here for a long time? And, who knows? One thing I just want to highlight, because I sometimes think that we've kind of become normalized to these incredibly high rates of infection, is that a year ago we were here at far less than 1% of people having COVID. And we were kind of in the middle of our massive vaccination campaign at this point, vaccinated most people with at least one dose over this period. And now, a year later, I don't think anyone would have thought this is where we are going into the summer, with basically no public health measures and massively high infections. looking at it just by age over the last few weeks in England, what is good is that you can see that it looks like the peak in primary school children has passed and is coming down. It's kind of stayed high and constant in secondary school, and high in older adults. The 70 plus are still going up, with the highest ever recorded at 7.2%. What is a little boring is you see these quite large increases in 16 to 34-year-olds, and it's not kind of clear what's driving that. So I'm hoping that that is going to come down over the next few weeks. In hospitals, there are kind of early signs. This is the number of people in hospital that these might be coming down. Northern Ireland is still coming down. Looks like it's flattening off in Scotland, England and Wales, which is good news because the NHS is under immense pressure, as we'll see in a minute. The admissions in England have effectively matched the peak that we had at the beginning of this year. It looks like it's just starting to flatten off. So hopefully it'll either peak this week or early next week. And you can see that, again, we got to about 2,000 admissions over about a week or so every day. If we look at it just for the oldest age groups, it looks like it is kind of flat and peaking for the 65 to 84-year-olds. But for the over 85s, it is still going up. So that's a little worrying. But hopefully as well, the spring booster program will make a difference. But the impact on the NHS, we're still seeing really high levels of staff absence, over 7% in England, which is much higher than in previous years, although it's still, isn't quite as bad as it was in January. But this is coming on top of a really difficult winter. In Scotland, the number of NHS staff absent has come down. So that kind of matches what we've seen in M&S, where Scotland looks like it peaked a week or two ago. I just want to kind of highlight something about ambulances. So this is the percentage of ambulances taking more than an hour to hand over patients. So ideally, you want to do it quicker than an hour. This is this year, 2021 to 2022 kind of winter. This is the kind of alpha wave winter last year. And this is pre-pandemic, or just at the beginning of the pandemic once you get to here. And you can see, over Christmas, there's a big dip as people tend not to call ambulances, but you can see that this year has been significantly worse. And then I just want to show you what happened since January, when normally this activity dies down. Now, over the last 2 years, it got a lot better and it was down to 2% or fewer handovers taking more than an hour. This year, it's got worse and worse and worse, and it's now over 12%. And that is what's driving these headlines that we've seen just this week of these huge strain on hospitals, huge strain on ambulance services and emergency services. I also just want to highlight a study that came out actually a couple of weeks ago now, which was looking at a survey of mental health in people who'd worked in intensive care over the various waves of COVID, and it was done last year, so it was all pre-Delta. And what they found was actually quite worrying. They did 3 rounds, one just before the worst of the alpha wave in December 2020, one in the middle of the wave, kind of January to February 2021, and one at the end of it, so basically a year ago now. And they showed that even a couple of months after the wave last year, almost half of staff had reported some form of mental health disorder, and it was kind of lots of depression, anxiety, and post-traumatic stress. And just to highlight, we have asked and are still asking so much from NHS staff, not in ICU, all across the board, and including social care. That we're seeing that there's an article in, I think, the BBC saying, it's winter pressures even in spring. I'm like, we've had winter pressures for almost a year. And there's no real sign of that changing anytime soon. And meanwhile, the backlog is continuing. So there has to be some element of support for the NHS, I think, going forwards. Just looking at deaths. This is deaths within 28 days by date of death. You can now see that the Omicron wave is starting to show itself. It's not clear, it's not going to peak just yet. I think we've still got a few more weeks, particularly as cases in the over 70s have not yet peaked. So I don't really know where that's going. However, we can see that if we look at ONS data, which is slightly more lagged, so 25th of March here, The most recent week has started to go up. I think it will still go up for the next 2 weeks. In Scotland, which has got 1 extra week of data up to the beginning of this month, you can see that it looks like deaths there have peaked from this wave, but that this wave was substantially worse than the January one and worse than any week they'd had under the Delta wave, although that lasted for a long time. If we look at children, this is kind of looking at, this is the prevalence of COVID in children by primary school and secondary school cohorts under 16 from ONS survey since May 2020. So basically since schools reopened. And you can see since then there have been 5 significant waves. They tend to peak at the end of term or the end of the half term. And then go down. So we've had, 1 big wave in Alpha, and then schools were shut over this period. And then we had the summer Delta wave, then we had the autumn Delta wave, then we had the early January Omicron 1 wave, and then we've just finishing the Omicron 2 wave. So there's been a lot of disruption to children's education and schooling over the last year and a bit. We look at children who are absent for COVID, we can now see this is coming down, which is good, and it kind of agrees with ONS showing that cases have peaked there, and it was lower than it was in the January wave. But for teachers, this isn't the case. So although it is coming down, it's still really, really high levels of teacher absence in schools, and that is going to be causing significant disruption. If we look at hospital admissions in children, you can very clearly see the Omicron peaks. That was the first one. This is the second one. Again, it's all consistent with that peak now being on the downward slope as admissions are falling. But, for children, basically, they've had their worst pandemic since the summer, especially primary school children who've not been vaccinated. Long COVID, so the ONS infection survey does a monthly report on the number of people who self-report ongoing symptoms after COVID. They released their latest report yesterday, and that's also showing now a record number of people reporting symptoms for at least 4 weeks, so almost 2 million people. And what I think is particularly interesting is this is the first time we've been able to see the impact of the Omicron wave, because this is infections up to the end of January of this year. And what ONS said is that of those 1.7 million, 334,000 are from infections that occurred in the Omicron period. So I think what that is saying, and what is concerning about it, and that this is over 300,000 people reporting long COVID in a population that is extremely highly vaccinated and with high levels of previous infection. So obviously we've had far more infections, but just that number of infections means that it is affecting a lot of people getting long COVID. And you can see this is by age group over time. So red is the most recent one, that we've seen increases in every single age group in the Omicron wave, but there are patterns here. So in children, you can see quite big increases just in the last month, and that will correspond to the fact that we had a big school wave in January. We had 20,000 more children reporting long symptoms over 4 weeks, most recently, compared to 46,000 in the month before. For young adults, actually, the peak in their infections was in December, and you're seeing that big increase from infections up to December and more modest increase over the most recent month. But for older adults, again, the peak was in January this year, and so you're seeing big increases in older adults, and that will be affecting people's ability to work. Now, the other thing to bear in mind is that we're just finishing another big wave that's as big or bigger than the one we had in January, and we will see that impact in a few months. We are creating a lot of long COVID with these high infection rates. There was new UK research into organ impairment and long COVID that came out a few weeks ago, where they did organ scans on people with long COVID, looking at them at 6 months post-infection and 12 months post-infection. So there's a lot of symptoms here in people at 6 months, and they do reduce at 12 months, but there's still a significant burden of symptoms at 12 months post-infection. most commonly is fatigue and muscle ache and shortness of breath. They also looked at, did organ scans on people and looked at a control group, which are the greys. And the main thing to take here is that everywhere there's a star, it means that for people with long COVID, it's significantly worse on an organ scan than it is for the control group. And that's a lot of different organs. And actually what they conclude is that when it comes to symptoms, extreme breathlessness, cognitive dysfunction, poor health-related quality of life were common at 6 and 12 months. And that there was significant issues in the heart, the pancreas, the kidney, the liver, and the lungs. So it's certainly not something that is particularly benign. Moving away from long COVID, there's also been just increasing studies now looking at the long-term impact of COVID infections on people in the year following infection. We've seen evidence that even mild infection can cause long-term heart problems. There was a big study from the UK Biobank where they showed there was an increased risk of hospitalisation and mortality. It was much higher for those who had severe initial illness, but it was even there in people who had mild infections. And they say, given the huge number of people infected by COVID, this does have implications. And just this week, there was another study that came out showing that there was a higher level of deep vein thrombosis, pulmonary embolism, and bleeding. These are essentially like blood clots and blood problems. And again, that's harder. So it's kind of effectively, you know, it's not a cold. And I just don't know how many times you have to say to people, but this is not a cold. And the number of infections we're allowing will have consequences. And I just finally want to have a quick scan on new variants to kind of give you a heads up as to what's going on there. At the moment, in the UK, Omicron variant BA2 is dominant. It's not a surprise it's dominant. The KHSA now says it has a 75% greater relative growth rate compared to BA1, which if you think how quickly Omicron took over Delta, and then BA2 effectively did the same thing to BA1 last month, it's now dominant all over Europe and has just become dominant in the US. But it's still mutating. So BA2 is still mutating. There are now several new BA2 subtypes in different countries, and some of them do seem to have a great advantage. So here is one, BA2.12.1 in the US and Canada. But there are others. So far, none of them are particularly concerning. None of them show any increased virulence or less vaccine efficacy, but they're, you know, it's still exploring its transmission space. There are also now recombinations of Delta, Omicron BA1 and Omicron BA2 coming forward. And what that means is that it's likely when someone is infected with both, they basically kind of swap bits and create a new variant. I'm sure the virologists on the stage are turning in there are not happy about me saying that. But anyway, if you have these three variants, Delta, BA1 and BA2, in the middle of March, we'd seen in the UK, one variant that was Delta plus BA1, one variant that was BA1 plus BA2, and one variant that was Delta plus BA1. And we've also just seen continuously new recombinations popping up. So basically in the last 2 weeks, there have been loads more popping up over the world and in the UK that are effectively all BA1 and BA2 coming together. And what it seems to so far is that the Delta plus BA1 variants can't outcompete BA2. They're not infectious enough. And we haven't seen hardly any Delta plus BA2 combinants. And that's probably because mostly Delta had died out by the time BA2 came. And I think we should be really glad that that's happened, because it means that we're not seeing Delta plus BA2, which is kind of what worries people, because you don't want the virulence of Delta and the infectiousness of BA2. Also this week has been announced two entirely new Omicron lineages, BA4 and BA5, first identified again in South Africa and Botswana. Now they're similar to BA2, which is our current variant, but they haven't evolved from BA2, they've emerged separately. And so the theory is that they've kind of come from whatever the same sources that Omicron arose from in November. And it looks like that's still going on and creating new variants. Now, what is a little concerning about it is that BA4 and BA5 do seem to be dominant now in South Africa. And we've seen a few in the UK and Denmark and Germany, but it's not clear what the implication is for the UK, we don't know anything about whether they're more virulent or more immunoevasive or anything like that. And also, we've had much bigger BA2 waves than South Africa. So it's not clear that even if South Africa has a new wave, that it will happen here. But it's just something to kind of keep an eye on. And finally, there's a potential for an entirely new variant that we just don't know about. So far, Omicron didn't come from Delta and Delta didn't come from Alpha. And so there's not they're all kind of quite unpredictable. So it could be that the next concerning lineage could be something completely different. It could be from Omicron, and it could be, a recombinant. But what the point is that there's so much COVID around the world right now. It's continuing to evolve. And this is definitely not the last wave. So summarizing, we are making good progress in giving vulnerable adults a fourth jab. There's no data yet on progress on the 5 to 11-year-olds. ONS shows that the number of people with COVID remains really high in all nations. We're likely now at or just beyond peak in England and Wales. Scotland is coming down, and Northern Ireland is just high. So it's not quite clear kind of what's going on there. The number of people in hospital remains high in all nations. The NHS, particularly in England, is under extreme pressure right now. Deaths in Scotland are coming down. They're rising a little bit in England and Wales, but deaths in England and Wales have not yet peaked. There's been significant disruption in schools all term. This has continued right up until the end of term. So hopefully next term will be better. But, I'm not hearing or seeing particular efforts to make schools safer spaces. It seems like, the emphasis on improved ventilation and air purification isn't happening. Hopefully it will be easier to open windows, at least in the summer term. Long COVID is increasing following the Omicron BA1 surge in January. And this is in a highly vaccinated and highly previously infected population. We have not yet seen the impact of the most recent wave. And we're also getting loads more research coming out about other long-term impacts of COVID, and they're not particularly good impacts. And finally, Omicron BA2 is dominant and it remains dominant, but there are a lot of things going on in variant space, and it's not over. So I will end there.
Christina, thank you for a brilliant presentation and laying out this huge burden of illness, of long COVID, and it's pretty depressing. And my immediate thought was, what's the economic impact of all of this? I mean, we've seen the absences causing disruption in aviation, in the health service, in education, but across industry and reduced productivity amongst people with long COVID must be colossal. I mean, anyway, we'll come on to that. I have a couple of announcements to make. So with as Christina said, with the REACT study ending, with cases, admissions, deaths all rising, the government failing to follow the science, we want to make very clear that we are committed as Independent Sage to continue our weekly sessions indefinitely for as long as this pandemic lasts. I mean, we'd all hope to be back to academia by now and, in the pub and having siestas, but we're not. And I'm sure all of us appreciate hugely the fantastic rigor and attention to detail that Christina brings to these sessions each week. She gives a huge amount of her spare time to keep us all informed. But in future, we're going to be joined by some new experts or people that have helped us before to keep you informed and to answer your questions. So, for example, helping Christina with the data will be Dr. Deepti Gurdasani, who's a brilliant British Indian clinical epidemiologist, and she's senior lecturer in machine learning at the Queen Mary University of London. We'll also be having Kit Yates, our former regular presenter, coming back. He's a senior lecturer in the Department of Maths and co-director of the Centre for Mathematical Biology at the University of Bath. And he's also the author of a book called The Maths of Life and Death, 7 mathematical principles that shape our lives. There's a plug. And a final person helping to collate and explain the data will be Dr. Duncan Robertson, who's also been with us once before. He's a fellow of St. Catherine's College, Oxford, and a lecturer in management science at Loughborough University. He's also a mathematical modeler. So we've got some great people to help Christina. In addition, we're going to be joined from time to time by other experts, Professor Trish Greenhow, who's a professor of primary healthcare sciences, also from the University of Oxford, and she's also a practicing GP, and by Dr. Benita Kane, who we've had on once before, a consultant respiratory physician at Manchester University Foundation Trust, and also she's the co-founder of South Asian Heritage Month. Now, all the experts will provide independent, transparent, and candid expert advice without conflicts of interest. That's what we do. Now, just before we go to questions from the public, and we've got lots, one other thing. All our experts give their time for free, but behind the scenes, there are some costs to cover for administration and media support, and it adds up to about £2,200 per month. Now, the Citizens are a fabulous not-for-profit group. They help set us up. They've sustained us over the past 2 years with their media, technical, journalistic, PR advice. And today, this morning, they've launched a crowdfunder to cover some of these admin and media costs. And if any of you are able and willing to support this effort with a donation, no matter how small, we know everyone's under pressure right now, of course, we will be extremely grateful. And the link to this crowdfunder, I think, is going to be in the chat. And if someone can put it there, and we shall be sharing it on social media. So with that, now that I'm done with my updates and announcements, I think we can move on to the main session for today, which is your questions and answers. And we're going to start with the first one from Charles Spencer.
Good afternoon. Thank you very much for the invitation. I've followed Independent Sage as a layman throughout the pandemic and read widely besides. And I've been impressed with how clear the group and its guests have been on how to mitigate public health, social, and yes, the economic effects of the coronavirus pandemic. But I share the frustration that I hear from all of you, and particularly every week in Professor Pagel's voice, with the fact that governments have not taken up most of these suggestions. Worse, governments I'm exposed to in the Isle of Man, the UK, and some Canadian provinces have now simply given up and said we should live with COVID with almost no mandated mitigations or protections. So you people know the solutions, but how do we get them accepted and adopted? Other campaigns like seatbelts and drink driving succeeded in changing public attitudes and government policy. In Canada, for example, it is largely socially unacceptable as well as illegal to drink and drive, although I will say that took quite some time. While some of you get quoted in a very few mainstream media, the rest of us seem limited to preaching to the converted in the Twitter sphere. So my question is a public policy one, not a scientific one. With governments ignoring the problem, how do we help convert Indy Sage's analysis and advice into action? And should we or you enlist public relations experts or experienced activists to help?
Thank you. A very important question. How do you get expertise into policy and what's the relationship to that? And we're actually going to have a session on that in about 3 meetings time. And the second one is should we be using PR more effectively to get our messages across? Who would like to come to that first? I'm wondering whether Martin, is that your hand up, Martin?
Yeah, I suppose it is one for me, really, isn't it? Because some of you know, another hat I wear is as research director of the European Observatory on Health Systems and Policies, where I do work with governments across Europe and with international agencies. It is incredibly difficult in the UK. You know, I work in a lot of countries. I work with a lot of governments. I work with a lot of ministers. And this is the most difficult country to influence policy of the ones that I work in. And, you know, I think we actually do, we need really a citizens movement in all of this. We just need people to mobilize and to say, up with this, we will not put. One of the things that I wrote about, if people go to the British Medical Journal website, something I published this week, was often when scientists are asked, why is your evidence not, your advice not being taken up? And they say, and we've had this at a few meetings recently, well, of course, we provide the scientific evidence, but we know that ministers have other considerations to take into account. And what I've argued in this piece very strongly is that's actually not acceptable. We understand that ministers have other things to take into account, but they need to tell us what they are. What are the other issues? And then we can have a discussion as citizens and in broader public health, although a lot of what we talk about in this on Independent Sage is looking at those elements of public health that are related to the nature of the virus, to the behavioural response, and so on. Remember that within the research that we do, some of us do anyway, we do look at these big issues of public policy. We do look at governance. We do look at draw on political science, and we're perfectly capable of engaging with those issues. So if there is an issue about the cost of the response to the pandemic or its impact on economic growth, talk to us about it. Because some of us have done a lot of research on the contribution of health to the economy, for example. Some of us have done a lot of work on the impact of the relationship between health and employment and what can be done about it, the role of active labour market programmes and all sorts of things. We can talk about that. So we need to stop having this, well, we provide the evidence and they take other things into account and we don't understand that. We can engage with that. We can discuss all of those things, but we just need everybody to make the same point because, we know from the polling data, the sort of views that we're putting out have a high level of support in the population. It's not that we're the minority. We are actually what the views that we've been saying consistently have been supported by polling, but it's too easy to represent these views as being fringe when they're not. So we need to keep saying that too. And we need to keep changing the narrative, keep looking to influence the narrative. And the reality of it is that there are a lot of people out there who spend a lot of time and effort and yes, money to promote a different narrative. And some of them do have the ears of MPs in a way that we don't. And some of them do have the ears of sections of the media that are read by politicians that we don't. So I don't have a simple answer. I would just say it's difficult in the United Kingdom, much more so than in other countries I have much more experience with personally. But I think that we can do more by looking at how this narrative is developed. I don't know if that answers the question.
Thanks, Martin. I think Professor Susan Mickey wanted to say something. And then Stephen Rasher, and we'll finish on that for the three.
Well, I was going to mention a couple of initiatives that the behavioural subgroup of this committee have got going very successfully. One is headed by Professor Liz Stokoe, called Schools on the Doors, which is a way of signing what the safety of air quality in buildings is. And the other is getting employers to sign up to a workplace pledge of safety at work. But I will now hand over to Steve, because Steve has really been driving this and been making great progress with it.
Professor Rasher.
Perfectly pronounced, Anthony, perfectly. Two things. First of all, to pick up a point made by Martin, I think it really is important to stress that actually the positions that Independent Sage has taken up consistently have been supported by the public. The public has always wanted early action. It understands the science, it's following the science, it's doing what the WHO has said, and it's been against early lifting of protections and measures. And right now, a clear majority of the public think it is remarkable to end free testing. Remarkable to say that people who are infected needn't stay at home. I think the problem isn't the public and PR. I think the problem is very clearly a political one. I mean, this government is being held hostage by about 100 right-wing libertarian Tory MPs. The problem is political and needs to be resolved at that level. As I say, I don't think it's an issue of PR. The second thing is, then what do you do if the public has one position and the government isn't prepared to represent it? And I think the answer to that, and here I come on to Susan's point, is we have to begin to do things for ourselves. We have to begin to organise for ourselves. And so, as I say, one of the most egregious policy measures by this government, or lack of policy measures, is saying to people, you don't need to self-isolate if you are infected. And that has led to a number of instances where people have been actively pressured to go to work when they're infected, because staying at home is difficult. It costs money. And if we don't have decent sick pay, and if you don't have the support of employers, you can't do it. And our sense is the public feels very strongly they don't want infected people at their workplaces to infect other people, to infect them, to mean that vulnerable people aren't able to go to those particular places. There's a huge will to do something about it. And the pledge is a pledge to do something about it. It's something which we want to get signed by employers to give confidence to employees and to customers that that workplace will not have infected people who are serving them. And what we're doing at the moment is we're building up a coalition, what we might call a pledge coalition. And it's remarkable how much support there is for it. So there is consistent support from the trade unions in England, in Wales, and in Scotland. We've been contacting a raft of organisations who are very concerned. So organisations of bereaved families, of clinically vulnerable people, of long COVID groups and so on are coming behind it. On top of that, there are various public health organisations who are coming on board behind it. So in a sense, watch this space, because we're going to launch that, and that's something we can all do together. So to make sure that if employers do sign the pledge, that they keep to their word, that they make sure that they are protecting the public and protecting their employees. And if they don't sign the pledge, to get them to sign the pledge. So as I say, if the government isn't doing what it should, then we'll get the public to do what they should.
Thanks, Stephen. So we'll go on to the next question, and we may come back to some of these issues because that's such a big question, Charles. Let's go to Carolyn Brain. Is Carolyn with us? Yes, she is.
Hello, can you hear me?
We can.
Oh, right, okay. I have two questions. First of all, why has the government only now updated the full list of COVID symptoms? That's my first question. And the second question is, why is testing being stopped given the high COVID rates, and also given that other diseases are tested for? Thank you.
Well, couldn't have a better follow-up question, which is very specifically on the issue of why politicians are not exercising their judgment based on expertise rather than their convictions. This is the age-old question of political science. When you have a single sovereign state in charge of everything, do they follow the consequences and expertise or their own political convictions? Okay, so all right, I see Susan and Helen. Let's go to Helen first, because she is our clinician for today. Helen, why has the government only just given us the full list of symptoms?
Who knows? Who knows? I mean, there's quite a lot of us who for the last 18 months have been banging on about how the symptoms have been wrong and too narrow and have missed lots and lots of cases. If you are a real cynic, you might think that there was a relationship between actually here's another whole load of things you should test, symptoms you should be testing with, and by the way, you've got to buy the test. I'm not necessarily saying there is a connection between those two things, but it's a possibility, isn't it? I mean, I think it's the thing about COVID is it is has so many different guises. As a GP, there are some things that I don't need to test for. If you're coming with chickenpox, it has a really distinctive rash. Pretty much, I can tell you've got chickenpox, so I don't need to do a test. And sometimes you'll come in with another viral infection. I think that's what it is. You've got a runny nose. You've probably got a cold. And pre-COVID, I wouldn't do a test either because it wouldn't change what I advised you to do. It wouldn't alter any treatment I might give you. So there's no point in doing a test. But COVID is really different. COVID, it matters whether your runny nose and sore throat are to do with COVID or from another much less dangerous virus. And I'm now in a situation where if you as a patient come to me and I say, and you've got some symptoms which could well be COVID, they might not be, but they might be, and that now it's a much broader range of symptoms than have previously been discussed, I could say to you, I think this could be COVID. And then I can say, I think you should go and buy yourself a test. But not all my patients can afford to keep buying tests. And that's not how the NHS works. If your doctor thinks you might have a condition and what happens next depends on that diagnosis, then the NHS should be testing you. And it really does make no sense to me at all. Are
you allowed to prescribe a test, Helen, now?
No, I have no access to, I mean, maybe things will change, but up to now, don't have any tests to do there and then. I can't prescribe a test. The moment, all I can do is recommend you have one. And then up to last week, when there was, available public testing, your GP advising you to have a test was one of the reasons you could have one. But
so you can prescribe a test for TB, for malaria, for HIV, and it won't cost. It'll be free at the point of delivery, but you can't do that for
anything that needs to be tested for. Those tests are free. So it's a completely odd and out of context thing that, completely unlike our experience of the NHS up to this point. That if I think that it would be useful for you to know whether you have COVID, and frankly, if you've got symptoms, for most people it is, should you go to work? Should you visit your vulnerable relatives? Do I, as a doctor, need to be worrying about you and checking up on you if you're elderly? It's really important information to know if a patient has COVID, both to the patient and to the people around them and to the health service and those looking after them. If you go to hospital, you will probably be tested, but in a GP surgery, I can't do that now, and I can't ask for it on your behalf. I don't know something's going to have to change because it's a really dangerous situation.
Oh, well, that's something we can.
Sorry, I don't know whether that answers your question, Carolyn.
No, that helps very much. Thank you. I'll come to Susan quickly, Professor.
Yeah, I'll just pick up on the question about symptoms, and actually the answer is it's a mystery. We're in the dark, and one of the problems I think about the government's handling of the pandemic has been this lack of transparency. I mean, thinking back to when tiers were being imposed and taken out, we never knew what the criteria were. Now, in terms of the symptom list, we up until when tests stopped being free, there were only 3 symptoms there. These were the symptoms of Alpha, not even of Delta. So one answer we know is not the case, is it isn't that the government didn't know. The government knew what the symptoms were right since Delta days, but they chose not to put up the longer list of symptoms. In America, their Center for Disease Control, they had a list of, I think it was 9 symptoms that has been up for a long time, and other parts of the world similarly. Now, why? We just have to speculate as to why that is. I don't think it's a coincidence that suddenly, even though they had been asked by many, many scientists, and the case had been made for extending the list to a list that reflected reality, why did it suddenly come up when tests stopped being free? Now, one hypothesis is that when the government were paying for the tests, they didn't want so many tests being used, and so they just had this very narrow list. But once the responsibility had been dumped onto those who can afford to pay for the test, then they're quite happy to have this large list. But if you put together the lack of transparency over symptoms and the lack of education to people to understand and try and figure out what they have, alongside what Helen's just been describing about the lack of tests, we're in a pretty sorry state at the moment, I'd say.
Yeah, and we shouldn't be surprised that, one of the reasons medicine's so fascinating is there's the same germ, whether it's TB, malaria, or SARS-CoV-2, can cause a massive range of symptoms, everything from nothing to mild to moderate to severe, and affect, many different organs. So we shouldn't be surprised by that. Anyway, I think you've answered both questions. So we'll go on to the next one, which is Terry Harper. Terry.
Hi. First of all, thank you so much for all you are doing to put scientific facts out there in the public domain. And then my question is similar to, I think it was Charles, the first one. I wondered how you have found the media during the last 2 years, especially compared to other countries such as New Zealand or South Africa or Spain or any other countries that you're aware of. And in particular, what do you think that the media here could have done differently?
Well, we've got a few victims of the media here. So shall I come? I'll tell you what, I'll come to Zubaida first. You want to have a go at your experiences of the media, and then I'm sure some of the others, Martin, Christina, might have a view on this.
That's a really tricky but excellent question, Terry. It's really difficult, isn't it? Because in an ideal world, you'd want the media to be part of that democratic model where they hold the government to account. And I think at the beginning of the pandemic, there was some evidence that they were holding the government to account, and they were sharing some of Independent SAGE's concern about the lack of transparency around SAGE in terms of its members, around the government in terms of the scientific advice. You know, it was the entire reason we were set up. And I think certainly the media were concerned also about the government's purported mass infection, herd immunity strategy, if you remember back then. It's difficult because it feels as though things have certainly changed, and it certainly feels as though with the mainstream media that they are following the government's narrative that the pandemic's over. We're getting far fewer inquiries from the mainstream media. There's very few articles in there, considering that today we had, the ONS has revealed that we've got 1.7 million people with long COVID. You'd think that would be mainstream news everywhere, but there's hardly any mention of it. And certainly, as my colleagues have pointed out, when the government stopped self-isolation, when they stopped saying that self-isolation was mandatory, when they said that free testing was no longer going to continue, you would have thought that the most basic way of keeping us safe, that the media would be up in arms. And we haven't seen that as much. So I think there is huge concern. And I don't know why, I don't know what the reasons are there. As always, we could speculate, but it's not satisfactory. It's not satisfactory. And more than anything else, where the media are failing is in terms of holding the government to account and in terms of keeping the public safe.
Great, thank you. Christina, you've had a few punch-ups with the media. What do you think of them overall?
Well, I have, but I have also had a lot of good experiences. I mean, I think on the positive side, a lot of us have had lots of experience with the media, but I think it does show that there has been enormous interest in hearing directly from scientists, that the public want to hear and the media want to hear. And Independent SAGE has played a really important role in being part of that information and translating what is known in the scientific community for the public. And I hope that continues. I think there is a problem, as like Zubaida highlighted, about less reporting on the longer term impacts, particularly things like long COVID, but also some of the other stuff that I highlighted today. It's less immediate, it feels less urgent than the latest hospital admission figures, but it really, really matters. And it matters partly because this kind of idea that we can live with the virus by just having it at really high levels the whole time only makes sense if you assume there are no consequences to infection other than death. And we know that's not the case, right? We absolutely know that now, but we keep pretending it's the case because otherwise we have to do something. And that's where I think there does have to be a much bigger, broader discussion in the media, in the public, in policy making, in the government about how we do live with it. So Independent SAGE released our ideas a few weeks ago, but that has to happen and there has to be demand for it. Because otherwise we're just stuck where we are today and everyone's going to get a bit sicker every year and it's a bit grim.
Thanks very much. There's lots of, everyone's putting their hands up. I've got quite a few other questions. Steve had his hand up first, so I'll come to him. I would just say that there have been there are some great journalists around. I mean, you know, a lot of the people early on, I would name, you know, Beth Rigby, Kay Burley from Sky, all the Channel 4 team, even in the BBC, there've been some very good journalists and they're asking questions. I thought early on, some of the health reporting was quite poor in the sense that they missed a lot of the key points early on. But anyway, that's a small point, but you need a lively media, and we have a very lively media. Steve, do you want to make a quick comment?
Yeah. So, I mean, first of all, I completely agree with you. There are media and there are media, and there's been some superb media. I mean, if I was to recommend one thing that people should read, it comes from the Sunday Times Insight team. It's their book, Failures of State, and it's absolutely coruscating. Absolutely coruscating. You read that and you come away, you know, just amazed. So, you know, let's not lump all the media together. That's number one. But I think there are two systematic problems that have come about with the media. First, of course, is that the media likes controversy. Controversy breeds interest, and therefore it liked to set up conflict. So even when there was scientific consensus on various things, like the need to take action, it would seek out one or two people who departed from that mainstream and set them up as alternatives. And I think it did quite a lot to boost the herd immunity type of argument. That's problem number one. And problem number two, again, you know, the old adage, if it bleeds, it leads. So the media loved to have stories of people's misbehavior, of people, you know, having raves and parties and breaking the rules. And actually that contributed to undermining, I think, the public effort, because actually it was a misrepresentation. Most people were conforming, but once you're told that nobody else is conforming, it becomes a self-fulfilling prophecy. So what's the point of doing it yourself? So I think the media need to think much more carefully, and we need to have much more of a debate about responsibility of not boosting things in a way that you create pernicious self-fulfilling prophecies. So some really fantastic work, but some real problems we need to address for the future.
Thanks very much, Steve. Okay, I've got three more questions I want to get through. So let's go to Vicky, if she is on. Vicky Millions.
Hello.
Hi, Vicky.
My question is kind of leads on from what Christina said just now about highlighting what the issues are other than people dying. And I, from my conversations with people, it's obviously not very clearly coming through about the amounts of other diseases and the numbers that are getting these other diseases. Like anecdotally, I know someone who's got a 13-year-old, they've just got newly diagnosed diabetes and they had never any problems before. But I believe that probably what's needed is to do like a greater than expected comparison. So like how many were getting diabetes before COVID, before 2020, and how many are getting it now, or something like that, some hard data, so that people can look at it and say, oh, okay, this is what's happened as a result of COVID, and doesn't require any testing. It's like the more deaths than expected kind of comparison.
Yeah,
it can't be sort of scuppered by the government not allowing people to get tests and things like that. You know, that's it.
So I see. So you want a kind of excess deaths type thing applied to illness.
Yes.
You know, are we seeing upward trends in things like diabetes, heart attack, strokes?
Yes.
And many other things as a result that we're now seeing, you know, which could be in some way attributed to COVID. Christina.
I think the diabetes is quite an interesting one, because there has been some evidence, particularly from the States, that COVID is associated with an increased risk of presenting with new onset diabetes. I don't know how you would have a measure like an excess death type measure, and I'm not sure it's that useful to lump everything together, because it does matter what it is. But I do think we have to keep track of all the new research that's coming out about the different long-term impacts on organs, on things like diabetes, on things like increased risk of stroke, increased risk of heart attack, and make sure that those people then don't just get lumped in, oh, those people are already sick. They weren't already sick. We're actually creating more vulnerable people with every COVID wave that are then at higher risk in future COVID waves. I mean, it could be quite a vicious cycle. So how you do that, I don't know. I mean, Martin probably has some ideas as well, but it is really concerning, and I just don't think it's being taken seriously enough.
Yeah, and there's also been this stuff this week on the BMJ about, you know, the big increase in strokes and cardiovascular disease because of the clotting and bleeding effects of COVID and the way it influences bloodstream and stuff. So anyone, yeah, Martin. Oh, sorry, Helen first. Helen.
I was just going to say, I think it's just a flu crowd have done a lot of done everybody a big disservice, because people aren't realizing that they may get long COVID, and clearly that's a big thing, but also that their health will be worse. You know, people give up smoking because they're worried they're going to get lung cancer. Actually, maybe you should give up exposing yourself to COVID because you might get a blood clot and have a heart attack or get diabetes or all the other things that it looks like COVID might result in. And we absolutely need to both collect all that data, which is being collected, but also present it publicly so that people know it's not just a binary, you have COVID and you get better, or you have COVID and you die, but there are lots of other states in between, and it has a material effect, could have a material effect on your life in all sorts of other ways.
Yeah.
The other thing that I just wanted to add in here is the effect of ongoing COVID and our failures to do things about it on people's mental health, particularly people who feel very vulnerable. And there's a lot of kind of imaging, there's lots of stuff about COVID anxiety that makes me really, really annoyed. People have a right to be worried about getting COVID, and particularly people who are especially vulnerable. And this ongoing high prevalence of COVID is really, really bad for people who have, you know, people who are particularly vulnerable, have really restricted lives and has major effects on their mental health. It's not just how many people is it killing? It's so much more complicated than that.
Okay, I'm just going to go on to the next question because we're running short of time. Mick Coffey, is Mick Coffey with us?
Hello, have you got me?
Yeah,
okay.
Welcome.
Okay, thanks for taking my question. Is there any signs that some portion of the population is beginning to develop, even if somewhat imperfect, immunity through vaccination and increasingly infection? Or are many people just having patchy short-term immunity?
Yeah, that's a very good question. And you've asked it on a day where mysteriously our immunologist and 2 virologists are not available. So you're going to get an amateur answer rather than an expert answer. But maybe, I don't know, Martin, would you have something to say about that?
Oh, God. Well, no, I mean, I think the answer is we don't really know yet, unless anybody else does, because, you know, quite clearly what you do get is a degree, I mean, it seems like we're getting a degree of persisting immunity against some of the more severe manifestations. I think what we're realizing is the immune system is now incredibly complicated because there's the innate immune system, there's the mucosal immunity in your, upper respiratory tract, there's the antibodies and the T cells, and all of them are responding in slightly different ways. And I think you need to try to look at the changes over time in all of them to some extent. And the other problem that makes it more difficult is that the variants of the virus do have a different impact, particularly on the innate immune system, because some of the variants have actually been able to disable this interferon-mediated immunity, which is a sort of generic protection against viruses. So I think the answer is it's incredibly complicated. I'm not an immunologist, and I wish that Danny was here. But having read it through, I just realized that trying to make sense of all of this, when you've got changing levels of immunity because of the history of infection in the population and the vaccination, that's one thing. Waning immunity with waning of different aspects of the immunity at different periods, and newly emerging variants of the virus which interact, either escape from your immunity or may, in some cases, be able to sort of disable bits of it. Trying to make sense of all of that complexity is a bit like doing a jigsaw puzzle without a picture, to be perfectly honest. But there are immunologists who can actually make much more sense of it than I can, but I don't think that we can simplify it. But somebody might have a better answer than that.
No, thanks, Martin. I think we'll raise that at a future meeting, Mick, because it is going to come back more and more. And when Danny is around, I'm sure he'll give you a very good answer. We are actually at time. I just want to let people know that we're not, next week is Good Friday, so we're not meeting then, but we will be back the following week, which is the 22nd. And we will be focusing a little bit on that day with long COVID and its implications, incredibly important subject. The following week, we're going to have Aris Katsoukarakis, who is going to talk about variants and the evolution of the virus. The following week, we're going to have Dina, and as I mentioned before, and others leading on what does it mean following the science and how can we do that better in a modern society, the thing that was asked by Charles at the beginning. And then we've got a session on the NHS and the stress on the NHS. So we've got 4 really interesting subjects to cover coming up. Thank you very much to everyone who joined today. We thank you for all your questions, your feedback, those tuning in from homes. We're really grateful for all your support. We'll be back with you in a couple of weeks. Just to remind you of the crowdfunder that I described earlier, if any of you are able and willing to give just a few pounds to support that, that would be great. And we hope you all have an enjoyable Easter break, and we look forward to seeing you back on April the 22nd. Stay safe.
Bye.
So happy Easter.
Yeah.